Hello, good morning. This is Dr. Praveen Chandra from Medanta Medicity and here in Gurgaon. And along with me is Dr. Abhinav Chabra, who's going to be working with me on this case. So this patient he is going to present to you first, and then we will discuss.
Hello everyone, good morning. So this is our patient is a 63-year-old gentleman presented with acute coronary syndrome yesterday, having raised cardiac enzymes and STT changes in the ECG. His echo function ejection fraction is around 40 to 45% on presentation. So he has a previous history of angioplasty done in 2008, followed by a open heart surgery CABG in 2008, only after 3 months because of failed angioplasty. So at that time, RCA was stented and LAD was stented, followed by bypass was done to the ramus, circ, and LAD. RCA was not grafted. So yesterday, when the patient presented, we did the angiogram, which showed LAD having 100% occlusion.
The stent is also seen there.
Yes, we can see the stent in the proximal LAD. Circumflex is also 100% occluded. You can see the ramus, that capping of the ramus, which is also 100%. It is a large vessel.
And so here, Abhinav, what we see here is that there is nothing which we can do really to the native, because these days we have more inclination towards treating the native vessels in a post-CABG patient.
Yes, exactly.
So what you are showing is that there is all these native vessels are really degenerated.
Yes, we will
the
not
right is okay.
Yeah. So next. So the right coronary artery, which is having patent stent in the proximal RCA, and distal having some diffuse disease, but it is on to be kept on the medical management. Next. So this is the graft angiogram. Next. So this graft angiogram is showing proximal almost 95% occlusion, which has done that ACS yesterday. It is supplying the ramus intermedius. Next. So we can see it clearly in this view, proximal having almost 95% stenosis. Next. So this is the lima, which is supplying the LAD distally, LAD distally having diffuse this, but we will keep him on medications only for this also. So this is the next shoot. Next. Previous shoot. So this graft is supplying, SVG graft is supplying the distal circ, which is also showing almost 80 to 90% stenosis around
ulcerated plaque.
Yes, ulcerated plaque.
And proximally also it has some 50-60% disease.
So our plan will be to stent, because we cannot do much to the native vessel. So plan will be we will be treating the graft vessels.
The graft vessels, and if the patient remains stable, we can even do the distal RCA, which is in the PLV, because it's a substantially big vessel. So we might consider that. So we will see how things go. So the first thing is to treat the most culprit lesion first, and that is the one which we have taken a shot, as you can see. Show the first shot, please. So you can see that it's a very tight lesion, and it will be extremely, impossible to put a distal protection device through this tight stenosis. So first we'll have to treat this by some method, like either a balloon dilatation or a laser. And so we have chosen the laser because the chances of distal embolization will be lesser, and hopefully we will be able to get a good outcome here. And then followed by that, we will see whether we still want to put a distal protection or just put a stent straight away. So I have taken a 1.4 laser catheter, and we will do maybe 2-3 runs and see how things go. So this is the laser, and we will see how things move, and also keep monitoring that whether there is any slow flow, etc. or not. So this is the catheter which comes in now. Yeah. Okay.
Yes.
Okay. Check, please, little bit.
Yeah.
First, we will check, because we have to be very careful with the. Yeah. So we are just right there, and we are fine.
So we'll be flushing.
So we will keep flushing. The fluence is at 45. The rate is 25, and okay. So he is flushing it with saline. So once I'll say okay, flush on.
Yeah.
Then we'll start. Flush on.
Yeah.
Okay. Okay, so you saw that we were able to cross it very quickly, and because it is a although it was tight stenosis, but really not long at all. So we'll do 1 or 2 more runs. Check. Okay, and now it's fine. It's fine. It's fine.
Yeah, yesterday you told us
Yeah,
like
yeah.
you don't have to push it at
Yeah.
90 degree,
Yes,
never
yes.
lays at 90
So
degree.
we are not doing at angulation because sometimes there is a risk of perforation. Okay, so
Yes.
we are ready. Flushing. So he's flushing with saline. Okay, fine. Now you can check. It's always better to check in between because so we'll check. Let's check it. Yeah, looks
Yeah.
better. There is no incidence of slow flow here. We are still fine. Maybe you can, yeah, okay. So now you can do store it, please. Store these images and flushing on.
Yeah,
Flushing on. Okay. So once we are through, we will just pull it back without having the laser on, because the laser, should not be touching any, wall area, because there could be a chance of a perforation. Okay. Where you have to be very careful. Okay.
Flushing
So
on.
flushing on. Now it is much easier. So I'm doing these short runs with this 1.4. Normally I use a 0.9 catheter for native coronary circulation, but this is a big vessel. And in here I'm choosing a 1.4. Actually, I was having a discussion with Dr. Samir Mehta, who has done hundreds of these cases. And he published in 1992-93 about these laser and vein grafts. So his observation was also that, we should take a bigger catheter and not too many passes. But now we will see how things move here. Okay, flushing on. On?
Yes.
Okay. Okay. So these are the short runs, and as you can see here, since it is an angulated area, I will not, do it while I'm coming back, because then the rays will go down
Yes.
and touch the wall of the vessel. So I just want to touch the atheroma. Yeah, you see it jumps inside a little bit. Okay. Ready?
Ready.
Flushing.
Flushing on. Yes.
Okay, so we can check now. Take a shot. Now we'll take a shot. Okay. Oh, that's nice. So slow flow is not apparent here, and I think at this stage we can do a IVUS also to see what is the size of this vein graft. Okay. We can at this stage even put a distal protection device, but I think it may not be so necessary. Looking at the graft, I'm doing a IVUS to see how it looks, and maybe have some more idea about the sizing and the nature of this stenosis. But since but definitely it was a fibrotic lesion, and also that the degeneration was not that much. So it presented like acute coronary syndrome. Yeah. Okay.
Plaque burden is high.
So this is quite a lot of, some degeneration here. Distally, this is the size. Can you check?
3.5.
Yeah.
Fluorosafe.
Okay. Fluorosafe, please. So now you can see the IVUS that we have disease which is quite a bulky plaque out here, and proximally it is a good, I think, a 3.5. Tell the measurements, please. Yeah. So this is the length. So with this also we can assess the length of the stent which we are going to use. So here I can see that it could well be a 33.
Yes.
Yeah. So distally it is 3.5 or 3?
3.
Yeah, distal, please. Distal.
Oh,
3.3. Yeah. So we have, we can use a 3 also, we can use a 3.5. I will prefer to use a 3.5 because I don't want to go to very high pressures. Okay.
Yes.
Give me a 3.5. We have a 3.5 into 32. Yeah.
32.
Give me a 32. So we are taking a SR Summit, which is a Robicol plus sirolimus eluting stent with no polymer. And so we are specially choosing this device for vein graft, as we still do not know what is the the best device for this thing, but maybe without the polymer stent will be better. Okay, fine. So this is a 3.5 into 32.
32.
32. Okay. So this is a 3.5 into 32. We still not have much information about the use of drug-eluting balloons in
In
this.
the vein grafts.
Maybe one day we will have to do drug-eluting balloons here. But I was because before drug-eluting balloons, we still have to get a lumen, and to do that, there may be higher chances if you use a cutting balloon. There will be higher chances of
Distal
slow flow,
lamina.
etc.
Yes.
So let's see how it goes. Okay, yeah. So you can see that we are having some difficulty here in crossing. Now we have crossed. Can you check, please? Yeah. So we are fine.
Yes.
Check a little bit more. Check. That's fine. Okay. Check. Okay, I think we are fine.
Yes.
We are absolutely fine. Go up, please. 1, 2, 3, 4, 5, 6, 7, 8. Okay, so this is a fibrotic lesion here. 9, 10, 11. Okay, so we are at 11, and it's expanding slowly, gradually. Well expanded now. And let's see how it is. So it is now at 11. Make it 12. 12. So we generally do a 30 seconds inflation, stop. And as you saw that at 10 seconds, the stent was not dilated. At 30 seconds, it was fully dilated. Deflate, please. Okay, deflate. Okay. Okay. So we'll give some nitro. Nitro, please. Nitro and maybe some nicorandil. You have nicorandil? Nicorandil. Yeah, the ECG is okay. The hemodynamics are still fine.
Okay.
And we will give some, what is this?
Antigen.
Nitro. So the BP is okay. We can give some nitroglycerin. And are you having some nicorandil?
Yes.
Okay, diltiazem, little bit of diltiazem. So we give all this cocktail and this before we take a shoot and see how it is. Okay.
This is diltiazem.
Yeah.
This is nicoran.
Okay.
Nicoran.
What is this?
Nicorandil.
Nicorandil. Okay. So everything in, and now we can take a shoot. Okay. So that's beautiful. So no slow flow, nothing. The stent looks fully expanded, and I'm quite happy actually with this result. Okay. So shall we do an IVUS?
Yes.
To see if we need to do, but angiographically, I'm absolutely convinced that if the lumen is good, I will leave it like that, because these vein grafts have a tendency of going into slow flow if you dilate them too much. We went up to 12 atmospheres with that stent, and you saw that the stent expanded well.
Touch me.
Be careful. Usko karo, clean.
Touch way.
So we are trying to now do an IVUS run. So this is the proximal. Yeah.
Yes.
Okay. Pull back. So the distal edge is fine. Here the stent looks well expanded.
Here
At this place, maybe, I mean, still, if the MSA is good, I will leave it. Otherwise, I will do it. Okay. So fine. Okay. So tell the MSA, please. So it is 5.4. Area is 5.4. I think it's quite good. So we don't need to really do anything about it. And I will take this out. Okay. Right. So this graft is done. Now we will go to the, come to the RO, please. We'll go to the other graft, which is the graft to the OM. Normally I have this, if there are two grafts, I do it in succession, one by one in two settings. But here, since the first graft went very well, we can go to the other graft now. Yeah. So this is the second one. Let's take a shoot. Yeah. Okay. Fine. So this also has a great degree of ulceration. Let's have the wire, please.
Wire.
Okay. Wire. So this is the same BMW I'm going to use, and patient's BP is okay, ECG is fine, and we are now heading. So many times, we keep discussing whether we should do these or not. So those patients who are asymptomatic, certainly I will not touch them. But since he was very symptomatic, unstable for the last few days, we are going to treat these two lesions at least, and then the native vessel. If we have the time, we will do it today. Okay. Check please. I will go in a small, bigger branch. Okay, fine. So we are in a big branch now, later. And this lesion also looks very, I mean, this is in terms of angiographic appearance, this looks also ulcerated and having some degree of degeneration. So we can use the same catheter for the laser. Okay. So let's see whether this catheter goes easily or has some difficulties. Up till now, so far, smooth. Yeah, okay. Maybe we can check now. Check please, little bit. Yeah, it's okay. So we can do that. Okay. Right, okay. Flush it.
Flushed.
Are you flushing?
Yes.
Okay.
Flushed.
So we have flushed, and we'll do some runs here. Okay, ready?
Ready.
Flushing?
Flushing.
Okay.
Ready.
Ready? Please make it ready. So we switch it on to ready mode. So check please. Show me the last shot, please. So we'll use these wires as markers to know where we have to start and where we have to end, because we have not moved the table at all. So this is the starting point. Okay. Yeah. Ready?
Ready.
Flushing?
Flushing.
Yeah. So I'm doing these very short, quick runs, and not too much energy here. Okay, ready?
Ready.
Fine. So now maybe we can check at this stage. So we should be a little careful. Check, please. Okay, I think it looks very good now. Yeah, so we can do one more quick run and that's it. So you see that, we have really burned the lesion a little bit here. Yeah, okay, fine. Flush, please.
Flushing.
Flushing. Flushing.
Flushing on.
Okay. Okay, so I'll take this out. Okay. So the same 1.4 catheter we used for the second vein graft. And now we can check, give some nitro, please. So I'm going to do the IVUS and see how it looks. Yeah, hold the wire, please. Now the question is, sometimes people may discuss whether to use IVUS or OCT. I think for initial evaluation, using IVUS is better. What do you think?
Yes.
Yeah, to sizing and everything. It may be because IVUS always gives a lumen wise and also the size wise, it gives more accurate information. So this is a volcano IVUS, and now I'm going distal to this. Okay, you can check now.
Crossed.
Check, please. Yeah, so this is the landing zone. Okay, so this is our landing zone just above the branch, which looks like a 3, and you can see that the whole vessel is treated.
Yes.
I mean, even if we don't stent it, it's fine.
Deb is better.
Yeah, so we can try and see if we can just drug-eluting balloon it, because the lumen looks quite good after the laser. So maybe it was a little bit of thrombus and degeneration, which was there. Okay. Yeah, the lesion looks much better, but we will give some nitrodilzim, etc. at this stage. Give some nitrodilzim. And we can take a short stent, maybe a 3 millimeter, because we still do not have as much information about drug-eluting balloons in these situations. So I'll use a 312. 312 is our summit, which is again the same Probicol plus sirolimus eluting stent, and which is actually Probicol is the drug which controls the release of this sirolimus from the stent, and there is no polymer coating on this. Okay, give me this thing. Nicorandil. The ECG is okay. So we have to look at the clinical factors. Patient is asymptomatic. The ECG is okay. The hemodynamics is okay. So keeping all this in mind, we will go ahead with the second stent, and 312 or 316.
12 is fine.
12 should be okay. Yes. 12 is okay. Yeah. Let's have 312. But this is fascinating to see that the lumen looks very good on the IVUS after the laser, which was a 1.4 laser. And this is a 3 into. So this is a 3 into 12. Okay. So now in this era of where we have to minimize the contrast, I always try to use the landmarks which are there. So we can just do a gentle shot over here. Okay. Yeah, that's fine.
Yes.
Okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8. So you see that at 8 atmospheres, there is no residual. So we can go up to 9, 10. That's all. No more high pressures. And we keep it for about 30 seconds. So it is 16, 18 seconds. So this is our practice now, that in stent expansion, we give 30 seconds. And this reduces the chances of post-dilatation sometimes. Deflate, please. 30 seconds. Okay. So again, that looks beautiful. So the flow is good, and lumen also looks very decent. So we are fine. And we can give some Nicorandil at this stage. So we use liberal Nicorandil because Nicorandil gives a lot of vasodilatation to those small capillaries. And interestingly, you saw that even if it was a ulceration, degeneration, some thrombus, There was no incidence of slow flow in both these vein grafts. Okay. Yeah. Fine. Okay. Ready? Yeah, that looks nice to me. So the flow is good. TME3, all the branches are filling nicely. The blush is good, complete. And we don't need to post dilate also. Should we check? Should we do an IVUS? We can. We can do an IVUS to confirm. Get us a RCA guiding catheter.
RCA catheter.
So this is again the Volcano, which we use commonly, IVUS system, and with this markers, it is much easier to measure the vessel's length, etc. So here I am in the distal segment beyond the branch, and this is the, oh yeah, that's beautiful. Yeah. So, okay, fine, stop please. Can you measure? So you can see that we got a good MSA out here, 5.8, which I'm quite happy with. And the distal and the proximal edges are okay. We don't need to do anything further, right? And because, there are two things. There is always a razor thin edge. And if apparently everything is okay, the flow is okay, the lumen is good, no dissections, I will not try to go any further and leave it like that. Okay. Okay, fine. So this is out, and we'll take out this guide catheter, which was a multi-purpose guide catheter, 7 French, which we use for the vein grafts. We'll take the RCA, 7 French RCA. Now we'll go to the right coronary. So these two lesions did very well, and we are quite happy with this. Okay. So show the RCA lesion from the angiogram, just for recapitulation purposes. Okay, so we are now heading towards the native RCA, which is proximally everything is okay. It is, although calcified, we might find some difficulties in going through. So we are aware of that. We can check now. Yeah, that's right. Okay. So we can take a shoot. Iliocranial, please. Iliocranial. Sure. Yeah. So this is the native right coronary artery. We are going to check. Okay. So this is the lesion in the distal segment. Epicranial, please. Right now, it doesn't look all that critical. Epicranial, please. We have to see. Okay, take a shoot. That is the point. Okay. So we will see if we are able to go through this. Give me a wire, please, BMW. And also in this situation, we might have to use a guide extension catheter, because there will be issues of crossing this distal lesion in from the proximal very calcified segments. To also get a EL guide +2, which is from Nipro. Okay, LAO, please go to LAO. Check, please. Check. Yeah, so up till now, the wire movement is fine. Okay. Okay.
Yes.
Epicranial.
Epicranial. ठीक.
Check, please. Oh,
Yes.
guiding has jumped. Okay. Come back. Come. Let me see the guiding. You saw? So suddenly I saw there was a jump in the wire, so which means that the guiding has backed off a little bit. So I will see. Okay. Check, please. Yeah. Okay. No. And here, so this guiding is not going to help us too much. So that is why I have already thought of taking a extension, guide extension, which is the guide plus 2 catheter. Okay. Yeah,
Yes.
we are in good position now. Okay, so get me a guide extension, please. Yeah. And a 2 millimeter balloon. So here we are not going to use any laser
And
because it is number 1 to distal, yes. And give me a 2 millimeter balloon, please. 2 millimeter. So as you saw that, since these two vein grafts did not create much problem, luckily, so we are now heading towards the third lesion in this native coronary artery. And this is the guide extension, LO, so that it is visible. So show in the LO, please, where we are. LO. Yeah. So we are coming to the LO, and you can see that the guide extension is quite deep inside. So I will not push it now. We will push it only when it is required, because otherwise it may lead to continuous ischemia of the right artery. 212 is okay. Yeah. 215. Yeah, 215 is better. So we'll take a 215 mini track, which is a semi-compliant balloon, because the crossability of this will be much better as a starting point, and we'll also know how it is moving. So this is the 2 millimeter into 15. How much heparin have we given?
10,000 ACT.
Can we give some 2,500 more? 2,500 more. Yeah. Okay. So I will move this catheter and see how it is moving. Up till now, no problems. Okay, come to this view. Iliocranial. Okay, okay, okay. Okay, so I'll push the guide extension a little bit so that we don't keep having the support. And here we are needing some support. Okay. Okay, fine. So we are in the distal part. Now I will move the guide extension back into the guiding catheter, because we have pulled where's the balloon gone? Balloon is gone inside. Okay. Check, please. Check. Okay. Okay. Go up. 2, 4, 6, 8, 10, 12, 14, 16, deflate. So I can take a shoot now to assess the length of this lesion. Yeah. So you can see that it's a long diffuse disease, and
we have to start from the bend.
Yeah. So we can do an IVUS also if possible, because sometimes these vessels look small, but they are not so small. And I'll try if we can take the IVUS catheter there. Stop, please. So there can be some challenges and pushing this catheter, but we have already taken an extended lumen. This is the extended lumen. There are two lumens, and this extended lumen guide catheter is the guide +2 with a lumen of 1.43. So the other one is 1.3, which is the standard. So I'll try to see how we move, and I'll push this guide cap. Okay. So up till now, it's okay. Okay. So here, this is the calcific point. Can you check now where we are? Okay, so this is the point where calcium is starting, and so we might have to do a long one. Okay, so this is vessel is looking like a 2.5 at least, which was on angio was looking like 2, and all of this is diseased. Okay, so I'm going gradually inside, and we can do a check shoot to see how long the stent has to be. So this is a good measure. So you can see there is 32, so we have to take 36. A 38. Okay, 38.
36.
Okay.
36.
We have 40. A 36.
2.5, 36.
36 might be a little short.
38.
What other size we have? So I'm pulling the guide extension a little bit back so that we don't have ischemia for a long time. So we can take a 2.5 into, show me the last shot, please. Last shot. So this is a length is 32, because this whole length, each marker is 10 millimeter apart, 10, 10, 20, 30 plus this is 2.5. So which means it is 32.5, 33. So minimum we need a 36 is better. 36. Okay. We'll take a 36 or a 38. Or maybe a 40 is also fine. Give me a 40 then. 2.5. SR. Give me. I think we can do some more dilatation. Not required. I don't think it's required. Yeah, because the catheter has, the IVUS catheter has gone quite deep inside. So which means we should not be having any problems while we are doing the stenting.
44 or 32?
No. We need a 2.5 into 32 will be short. No. So we can only take a, what is the distal vessel size? 2.5 or 2.75? On IVUS, let me know. Distal. Go distal. Okay. This is like, it can take a 2.75.
Yes.
And this is what, 44? No, that's too long. Give me a 2.5, 40. This one. You can give me a cruise. Or a 38 expedition may also be a good idea. Alpine, 2.5, 38. Give me a 2.5, 38.
But
or 40 cruise.
The lesion is starting from that point.
Yeah, from this point.
No, sir. This 10 marker is, I think it's normal only. So 32 we can take 2.5 if we are considering.
I mean, 32 will be small. No, 2.5. I want a 2.5 into either a 38 or a 40. Yeah, any one of them will be fine. And yes, that'll be fine. So we'll take a 2.5 into 38. This is Alpine, Zine's Alpine, and see how it moves. Have you given heparin?
Yes, sir.
So we'll keep a track in long procedures. We should keep a track of heparin always, and keep checking the ACT in between. Okay. So everything is okay. And okay, now I will push the guide liner slide inside slowly, gradually, so that we have a good support and the stent goes in easily. Okay. So we have the guide liner deep inside. Okay. Yeah. Check, please. Connect quickly. Where is the stent gone? Every time you push the stent distally. Check, please. No, I am fine now. I am fine now. Okay. Take a quick shot, quick little. Yeah, this looks fine to me. Okay. Go to the LEO position. I will just bring this back a little bit because the artery is getting some obstruction because of the guideline now. Go to, okay, fine. Check, please. Yeah, this looks fine to me. A little bit distal we can go. Yeah, we can go a little distal. We have some space there. Okay, okay. Check, please.
We are leaving that area.
Distally, we're okay.
Yeah.
Are we okay distally?
Not covering the whole.
Yeah, no, it's okay. It's okay. We can bring it a little bit back. Okay. Check, please. It is just right size. Just little bit here and there, and that's it. It's absolutely very cut to cut size, you know. What it means. Yeah, check, please. Yeah. Okay, go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, so we went up to 10 atmospheres, and so the nominal is 9 with the alpine. Yeah, okay. So that looks good. Deflate, please. So this was 30 seconds, and I'm going to
10 is nominal.
go up a little bit again. Pull it back a little bit. Okay, yeah, go up, please. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Okay, fine. So looks good. Maybe we'll have to do some more dilatations. Deflate, please. And take a 2.75. What was the proximal vessel size? 3 or 2.75? Okay.
Proximally.
Proximal. So this is a 2.5 into 38 alpine, and so there is some wedging. I can see that. Maybe I'll have to pull the guiding catheter a little bit back. Yeah, it's okay. So you saw that there was some wedging because the guide catheter went a little inside, and we can check now. Check now, please. Yeah, this looks very good. So we can do a post dilatation, and in the proximal part of the stent, it is at least 2.75 or 3.
Extension went in.
Guide extension has gone in because of that injection.
Flush.
Yeah, flush injection. Yeah. So can you give me a balloon, please? So we can take the proximal vessel size was how much? 3? 2.75.
2.75. 2.75 ish.
2.75. Proximal. .75 should be okay. So give me a 2.75 into 12 high pressure NC balloon. Yes. So we'll do the post dilatation and see how things go. Okay. Show me the last shot, please. Run the last shot. Yeah. So this looks very good. And distally, I think we should do with a 2.5, or maybe with this only we can do it. And just inside the stent edge. Okay. So I'll use the same balloon for the dilatation of the proximal and the distal part of the stent. Distally, we'll go with the lesser pressures. And so it is having some difficulty. I can see that the wire is pulling back a little bit. Check. Okay. Okay, so the guide liner is inside, which is our guide extension catheter. And now you can see that the balloon moved so easily inside. Okay.
Yes.
So our stent is very much, the balloon is inside the stent. And now I can pull back the guide extension. Okay. So you can see on this image that we are quite inside. Show me the star. That's right. The stent boost. Okay, go up, please. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay. I cannot go too much on this. We'll wait for a few seconds. It is expanding. So we must give some time for the balloon to expand the lesion. And you see that it is very well expanded now. Okay, deflate. So can you move this thing a little bit so that I can see the stent well? LEO, please. Plain LEO. Yeah, plain LEO. Yeah. No, I cannot. Okay. Move it. Okay. Okay, go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10. Keep it there for 10 seconds, 20 seconds. Now it is expanding slowly. So these fibrotic lesions sometimes take their own time to expand. 12. Yes. Deflate. 12. 14. So proximally, as you saw that there was a calcific ring there, which we are going to break, deflate. And I'll go to higher pressures in the proximal segment of the stent. Okay. Yeah. So we are just at the stent edge. Go up, please. Go up. Yeah. Go up 2, 4, 6, 8, 10, 12, 14, 16, 18, 20. Yeah. So we have gone to very high pressures and looks like that it is giving way. It has given way. Yeah. Okay. Deflate, please. Deflate. Okay. So we can take a check shoot. Looks nice. So to me, it looks good. We can do a IVUS if you really want to see how expanded it looks, but it looks very good. Very good. Okay, so come to the epicranial, again, iliocranial position. IVUS, please. Show me the, I want to put the wire a little bit distally, because if we are doing IVUS, sometimes we need better support of the wire. So check it. So this is fine. Okay. We are deep inside and I'm taking the IVUS catheter now. So you want to do OCT or IVUS? IVUS is okay?
Yes, OCT catheter will be short.
OCT will be having
length issues.
Very, issues because distally the vessel does not have that much space. So this is something which has to be kept in mind while we are doing OCT and IVUS, that the distal vessel, does it have enough space or not? So now I'll push the guide +2 catheter a little bit inside, which moves very easily, and I have crossed the stent. Okay. So now I'll pull back the guide +2 back again, because I don't want this continued ischemia. Okay. So I'm pulling it back. Now look at the IVUS. Yeah. So yeah, there is some plaque here. Yeah, now the stent is quite good. Well expanded. There is no distal dissection. There's some disease there, or in any case, little plaque there. We might like to put one small stent there. 2.5 into 8. Otherwise, it is expanded, but here we can expand more. We can go to higher pressures. Yeah. Yeah. But proximally, it is very good. Proximally, the stent is very well expanded. Yeah, very nice. Okay.
RC proximal lesion also, sir.
We
Guide
can
is
check.
major.
We can check, but I think it should be okay because we have been moving quite easily. And show me the distal. Show me the angio picture on angiographic image. This looks quite good. Okay. Go back.
Malone
Go back.
2.7.
Go back. Go back. We can take an angiographic image over here before we think of putting another stent, because there is some disease just distal to the stent. Show the distal. I mean, there is a plaque
Calcified.
and
Nodule.
just distal to the stent. We can put a 2.5 into 8. Why not? Yeah, we can, because the lumen is how much?
So it is.
How is the lumen there?
Human wise, it's good.
The lumen is about 2.2 and the area is 2.5. And come to the instant area. This much. So there is no dissection, but there is a small plaque come inside 4.0. It is about 50%. And what is the size of the vessel here distally? Distally, yeah. 2.25 might also be fine. Okay. So we can take a 2.25 into 8. Give me a 2.25 into 8. Yes. Yeah. Yeah.
Guide extension is
Guide extension, we'll pull back a little bit. Yeah. Show me. Show me the guide extension.
Oh.
So when we inject, sometimes these guide extensions actually move inside. Okay.
Guide
Yeah.
catheter दिखा.
Show me the guide catheter. Okay. Okay. Fine. Yeah. Okay. Open. Pressures. Okay. So now I will take the stent, which is a 2.25 into 8. So I'm taking a very short stent for the distal area. Had we taken a 40, it might have covered it. But 2.5 was 838 was little, just a millimeter issue. Okay. Okay. So I will use the guide extension again. Show me the guide extension catheter.
The guide is out.
Yeah, guide sometimes gets pushed back a little bit. So we will keep checking. Okay. And I will go a little. So this is not able to go inside. We might have to do some dilatations. So you see that this is having some resistance here. Yeah. I'll take this out. Dilate the stent more, little bit more.
Wedging, sir.
Yeah, I'll take it out. Yeah, so we'll take this stent out and dilate this. Okay, okay, fine. Same balloon?
Same 2.7.
2.75. So we will put this balloon 2.75 back again, and do some more dilatations. Yeah. Let's have a look. Yeah, so the balloon crosses easily. Okay. Yeah. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14. 14. Deflate. Okay. So this dilated well. And now in this area where there was a stenosis narrowing a little bit. So go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14. Yeah. 16. Deflate. Okay. So this is a high pressure balloon. And here again, 16, 18, 18. Okay. Deflate. Okay. Proximally more. Yeah. Okay. Go up 2, 4, 6, 8, 10, 12, 14, 16, 18, 20, 20. Okay. So we went up to 20, almost like a 3 vessel. Deflate. Okay. No. Okay. So we are now out. And yes. Okay. All right. So this is that 2.25. Now you see it is moving so easily after the dilatation. Yeah. Even without the help of guide +2, we were able to go in. So it is always better to optimize the outcome, especially in 2.5 millimeter vessels. Again, it's always every time you push. Okay. So we should look at the stent boost now. Okay. I think it's overlapping very well. Go up. 2, 4, 6, 8, 9, 10, 12. Take 14. Take 16. Deflate. Okay. It is needing some more dilatations. Go up. 2, 4, 6, 8, 10, 12, 14, 16, 18. Deflate. So I think we are fine. So we will see how it looks. Okay, check please. This looks fine. I think to me, we are absolutely okay now. Okay.
Yes.
Fine. So with this, I think we are at the end of this long procedure with 3 vessels done. And as it is very clear now that with these kind of situations, using a laser was quite useful in a tight lesion where you cannot put a distal protection up front. Let's take a final shot. Okay. Final shot. Yeah, that's nice. Okay. So I'm taking everything out. Yeah. Okay. So doing a laser up front in a very tight stenosis of a vein graft, if we have to do it, is a good idea. And because you cannot put a distal protection, and then if you do a balloon dilatation, there is a higher chance of distal embolization and slow flow, etc. So that is why it is helpful. And then, of course, in degenerated vein grafts, we have seen quite good outcomes in this. The patient's pressure is good, his ECG is stable, and he is absolutely stable. So we will now stop here. Thank you very much for your attention. And if there are any questions, are there any questions?
Okay. Sheath.
Okay.
And you seal.
Thank you very much.